Hello, everyone, and welcome to Module 1A. Today, we will explore the intricacies of the critical care environment, emphasizing the significance of holistic care and the vital role of spirituality in patient management. As nurses, we know that caring for critically ill patients involves much more than addressing their physical needs. It requires an understanding of the psychological, emotional, and spiritual dimensions of their experience. My name is Jessica Granger, and throughout this presentation, I will guide you through these essential aspects using real-world examples and evidence-based practice to enhance your understanding. In the critical care setting, stress and anxiety are nearly universal experiences for patients and their families. For example, a patient intubated in the ICU may experience severe anxiety due to the inability to communicate, leading to an increased heart rate or elevated blood pressure, or both. The psychological response is not just limited to the patient. Families watching their loved ones suffer and may experience significant emotional stress, manifesting as sleep disturbances or difficulty concentrating. Understanding these effects is crucial because it allows us to identify stress early and intervene effectively. Environmental stressors like constant alarms going off, bright lights, and the sheer uncertainty of the situation further exacerbate and make those feelings worse. Recognizing these stressors help us create more supportive environment for both the patient and their family. I want you guys to think about any time that you have ever been in the hospital or an emergency department, or even just when you were sick and you were uncertain of things, and how that added to the stress of just everyday life. Remember that our patients, a lot of times when they are in the hospital, this is obviously not planned. And when they're in a critical care situation, whether it be the emergency department or an intensive care unit, pretty much these patients are at their worst and most vulnerable moment. And the stress and anxiety that it can occur for both the patient and the family is beyond comprehension for many people if you do not have the empathy for the patients. As nurses, we play a pivotal role in reducing the stress and anxiety for our patients and their families. One of the most effective strategies is patient-centered communication. And you ask yourself, what is that? For an example, it means just taking the time to explain the procedures in a very simple, reassuring language, which can significantly decrease a patient's anxiety. Also, we can create a calming environment by lowering the lights, reducing as much noise as possible, and allowing patients to have personal items like photographs, a favorite blanket, their cell phone. Providing clear, consistent information to both patients and the families helps to mitigate the fear of the unknown, which can be a major contributor to the stress in the ICU or the emergency room. Lastly, involving the patient in the care process not only eases their anxiety, but also empowers them, making them feel like they're active participants in their loved one's recovery. Again, I want you to think about if you've ever been the patient or a family member of somebody in the hospital. When providers walk into the room, nurses, and they're talking to each other and not at you, it makes you feel less than human. It adds to your stress when you don't understand what's going on. It actually can add even to more stress knowing what's going on and having decisions being made for you. Remember, critical care is like in the ICU, that is a very, very scary place for a lot of patients. Same thing with the emergency department. And there's so much unknown about what their prognosis is going to be, what's going to happen next. Do they have to have surgery tomorrow? Are they going to be able to go back to work? How are they going to pay their bills? How are they going to be able to take care of their family? Are they going to be able to finish school? There's just so many anxieties and worries on top of their health. And so communicating to your patients and making things as easy for them to understand what is happening, you're waiting on, and what to expect next goes so far in helping them ease their anxiety and reduce their stress. Family involvement in the critical care area is not just beneficial, it's basically essential. Research shows that patients who have families actively involved in their care often have better outcomes, such as shorter ICU stays and lower readmission rates. The presence of loved ones provides both emotional support that no healthcare provider can replace, but it also provides an extra set of ears for hearing information when providers come by and explain things. For example, a patient who hears the familiar voice of a family member may experience a decrease in anxiety level, which in turn can positively impact their recovery. Little side note, it's a personal story, but it's a good experience. So whenever I had my most recent child, she was in the neonatal ICU. And her heart rate was higher, her respiratory rate was higher, and the nurses said that every single time I came into the room and she heard my voice, which was comforting to her because she had heard my voice for so many months, all of a sudden her heart rate decreased, like in a good way. Her respiratory rate decreased in a good way, and she calmed down. So I know that that's a baby, but it's still similar. Just the calming presence of something that's known in an environment that's unknown goes a very long way. In addition, families often provide crucial information about the patient's history and preferences, especially when they're intubated or not coherent or even asleep. It's nice to have the family there to add details and context to the situation to provide better care for your patients. It's also important to recognize that family members are integral in decision-making processes, especially when the patient is unable to speak, including the family, especially if you have a pediatric patient, but the wife, the husband, the girlfriend, the boyfriend, the partner, the children, whatever it may be, including them in the care and educating them on what's going on, what to expect, lowers their anxiety level, makes them feel more informed. And I will tell you from my experience, when patients and families feel like they have no control over the situation, they will try to start controlling as much as they can. They will be on the call light more often. They will be more demanding in their demeanor. They will be more not willing. I don't want to say not willing, but they're a lot more not abrasive. That's probably the wrong word too. But they push back a lot more, and they're not. It's a lot harder for them to trust what you're saying and educating them on the best treatment plan and all that kind of stuff. So by being proactive, involving them in their care, communicating with them, letting them know what's going on ahead of time, it will go so far in making things smoother for everybody involved. The patients, the family, you as the nurse, the providers, everything. So holistic nursing care, this is a term I know you guys have heard many, many times. But holistic nursing care goes beyond just treating the disease, as you know. It involves addressing the whole person, body, mind, and spirit. To provide a truly holistic care, we must conduct a comprehensive assessment that includes not only the physical symptoms that our patients have, but also emotional and spiritual needs. Do not be afraid to ask and talk to your patients about the emotional and spiritual needs that they have, okay? I know that our society often shies away from these things, but it's just as simple as, do you have a faith belief? Would you like for me to get the chaplain? Would you like for me to pray with you? Would you like to talk about it? And these things make the patients feel, A, that you care, and hopefully that you do, but it also helps meet those needs beyond just the physical. So an example of this would be just asking the patient's spiritual beliefs that can provide insights into what may bring them comfort or peace during this stressful, crazy time. Additionally, understanding the family's history can also be incredibly valuable for you taking care of the patients. Another example is like knowing that a family has a strong tradition of faith can help guide us in offering spiritual support that aligns with their values. Again, ask. Don't be afraid to ask questions. As nurses, you get a ticket to ask anything you want. Just make sure you ask it in a professional manner. The goal is to create individualized care plans that are specific to each patient, and they also respect each patient's unique needs, ensuring that our care is not only effective, but also compassionate and respectful. When families are confronted with a loved one's critical illness, their reactions can vary widely. And trust me, this is something I can speak to 100%. Some may exhibit denial or disbelief, refusing to accept the severity of the situation. This might manifest as questioning the diagnosis or insisting that the patient will recover quickly despite a poor prognosis. Others may respond with anger or frustration, sometimes and often directed at the healthcare team, which can be challenging to manage, especially if you are the primary nurse taking care of that patient. Alternatively, some family members might withdraw or detach completely and emotionally from their loved ones and the whole situation, which could be mistaken for a lack of concern, but it often reflects their way of coping with overwhelming stress. They're the avoiders of the world. And then on the other hand, some families may constantly seek reassurance, asking the same questions repeatedly over and over and over again in an attempt to gain some sense of control over the situation. Recognizing these behaviors is crucial as a nurse because it allows us to provide the appropriate support and guidance during these difficult times. So, patients facing loss, whether it's the loss of health, the functionality of a limb, or even possibly that they've just been given a prognosis that they will be passing soon, losing their life. It requires compassionate care that addresses their emotional and psychological needs. Active listening is one of the most powerful tools we have as nurses. Simply being present and allowing the patient to express their fears and concerns without any judgment can provide immense relief to our patients. Providing emotional support, whether through words of comfort or simply just being there, being present, helps patients feel less isolated in their experience. It is also important to offer information and resources, such as connecting them with counseling services, support groups, and all that kind of stuff. Encouraging the patient to express their feelings openly can be incredibly therapeutic, helping them process their emotions in a healthy way. I will say on this that it's very easy for us to get focused on the actual medical diagnosis. We're task oriented in our core as nurses, but we need to not forget the emotional, psychological needs. I know you think that you're not going to forget those, but when you are pressed with 5,000 tasks, so many meds to do, you need a call report, you need to do X, Y, Z, it can be overwhelming. This is where, yes, if you have the time, go for it. And I've explained this in health assessment for many, many years to my students, and you guys might remember this. But they have done studies where nurses come in and doctors come in, stand up, interview patients, and they time them how long they're in the room. Then they compare them to a group of nurses and doctors that go into the room and sit down on a stool and interview and assess the patients as well. In reality, they spent the exact same amount of time in the room. But the group where the patients had nurses and physicians sit down, they perceived that their nurses and physicians and care team were in the room with them and spent you're not going to, I forgot the exact time, but it was like 3-4 times the amount of time that they actually spend in there. Whereas the group where the nurse and the physicians were standing, they actually perceived that they were in the room less than they actually were. Nobody actually got it right on the actual time spent. But these are some things to take into mind. It's not just the words you say, it's not just the tone of voice, but it's your body language. When you are dealing with our patients, when you're taking care of patients, you want to communicate through all of those things that you are here for them. You have all the time in the world, even if you don't. You want to sit down, open-ended question. Let's talk about it. Do you want to talk about it? It's okay. I have time. That is always going to be the more therapeutic way to communicate with a patient and make them feel like they're okay, and it helps address their needs, and they feel they gain trust with you, that you actually care about them as a person and they're not just some body laying in a bed. So spirituality is, we need to define it. So spirituality is a deeply personal aspect of a patient's life that can significantly influence how they cope with illness. It encompasses their beliefs, the things that they value, and a sense of connection to something greater than themselves, whether that's a higher power like God, nature, or just a broader purpose of life. In the critical care environment, spirituality can be a source of strength and comfort for many patients. For example, a patient with a strong religious faith might find peace in prayer or religious rituals, which can help them cope with the stress of their illness. Understanding a patient's spirituality is essential because it can impact their care decisions, such as end of life choices or the refusal or acceptance of certain treatments. As nurses, it's our role to respect and incorporate those spiritual needs into our care plan, ensuring that we are providing care that is truly holistic. And on that, again, another personal story, but it's applicable. So I've recently been in the hospital, and I can tell you for a fact that when I had friends and family, nursing care team, and the chaplain come and pray with me when I was very, very scared, it made the world of difference. And I know you can probably logically think that, but when you experience it yourself, it drives it home and it almost like imprints on your soul how important it is for us to meet those needs of our patients. Because on a personal level, I can't even tell you the just my outlook, the tears, my ability to fall asleep a little bit and get a little bit of rest, when I was in the ICU, it was just, it helped me cope. And so please do not take a patient's spirituality for granted. Everybody has spirituality. Doesn't mean that everybody believes in the same God as we do, but they do have something that they ascribe to, that they believe, that they have values, those kind of things. So talk to them about it and try to meet those needs. A little bit more on spirituality. Spirituality is actually multifaceted. I was kind of talking about this a second ago. It encompasses various elements that contribute to a person's overall well-being. Meaning and purpose are central to spirituality, giving an individual a sense of direction and understanding in life, especially during times of crisis. Faith and belief provide a foundation upon which many people rely on when facing uncertainty or adversity. I don't know about you, but that's definitely me. This could be religious faith or simply just a strong belief in the goodness of life or the resilience of the human spirit. Connectedness refers to the feeling of being part of something larger than oneself, which can be a powerful source of comfort in the critical care setting. Lastly, hope and resilience are often nurtured by spirituality, giving patients and families strength to endure the challenges that they are facing. Recognizing and supporting these elements can enhance the care that we provide, making it more compassionate and effective. So there is a mnemonic that I want you guys to know and remember out of all the mnemonics in the world. It's not like y'all don't have enough already, right? Okay, so the value mnemonic is an excellent tool to enhance communications with families in the critical care setting, and honestly, in any setting. But first, we must value what the family says. Okay, recognizing that their insights, their concerns, what they're seeing going on, their perspective, that is all invaluable to understanding the patient's needs. We also need to acknowledge the emotions, both positive and negative. It helps us build trust and rapport. And how you do that is like, I see that you are I see that you are crying. I see that, I'm detecting that you're stressed about this. Would you like to talk about it? It's not, you don't want to gaslight the patients. You want to acknowledge that they have emotions, whether they're good or bad, and talk to them about it and connect with your patients that way. Now, listening actively, what that means is it means giving our full attention to the family. It's not us sitting there talking to them as we're typing on the computer or looking at the monitor. It's taking the time to sit down on a stool. Now, if there's not a stool in the room, like kind of maybe leaning up against the counter where the sink is near the patient's bed, something where it just shows a relaxed, I have all the time in the world kind of communication to the patient. Okay, so it's giving them our full attention, but it's to both the family and the patient, showing that we're present and we're engaged in their care. Understanding the patient as a person, not just a medical case, not just like a number, allows us to provide care that is respectful and personalized. And then finally, eliciting questions and concerns from the family ensures that they feel heard and involved in the process. This approach not only improves communication, but fosters a collaborative environment where the family feels supported and valued. And again, I'm going to harp on this. A lot of times nurses want to just get in, get out. You have 1,000 tasks to do. I'm not going to ask them if they need anything, because what if they say, yeah, I need ice, I need this, I need that. And it's just going to add more tasks to my list. So I'm just going to go in, do what I need to do, and get out. That is the absolute wrong approach. Trust me, in my experience, please trust me, that if you just take a few seconds to include family and patients, let them know that you're here for them, and ask them if they have any questions, concerns, or if you can even just get them anything. You want a pillow, a blanket, blah, 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 whatever. It will literally cut down on your work like crazy. It will actually lower their needs, because it's when you meet their psychological, social needs, like I said, they don't call on the call light as often. Or, like, you're going to preemptively, they may say, and a lot of times they'll do something like, well, I'm feeling like the pain is kind of getting a little higher. Like, it's only like a 4 right now, but I'm going to want some pain medicine soon. And then you can think to yourself, for your time management, you know what? I have one more thing to go do in another patient room, and then I'm going to go grab that med and then come back. And then it's so much easier for you to know their needs, and then you can better plan it. Just because they tell you something that they need doesn't mean you have to drop what you're doing right then and there and take care of it. But then just communicate with them and just say, I'm going to go do this, and then I'm going to go do that, and then I'll be right back for that. Is that okay? Is that okay? If not, I can call my charge nurse or a friend to come in and help you out. It's so simple, and it goes so far. So, open versus closed visitation policies. Now, this can be contentious depending on where you work and who you're working with. There is a debate between open and closed visitation policies in the ICU and the ER around balancing patient-centered care with the need for rest and recovery, and also control. I'm just going to throw that out there. There's a perception that family members cause more work for nurses, and that can be true, but it also is the opposite, okay? Open visitation policies allow families to be present with their loved ones whenever they choose, providing continuous emotional support. This can be incredibly comforting for patients and families, fostering a sense of connection and involvement in that patient's care and the situation that's going on. However, there are potential downsides, such as disruptions to the patient's rest or the medical team's ability to provide care without interruptions. Closed visitation policies, on the other hand, prioritize the patient's needs for rest and the healthcare team's focus on care. However, these policies can make families feel excluded and or helpless. As nurses, we must find a balance between both of those, advocating for visitation policies that are flexible and considerate for both the patient's need for rest and the family's need to be involved in care. So I will tell you that there's a lot of ERs that will tell you that there's a 2-visitor like policy. There's like no policy about that. Show it to me. That is just kind of like a kind of an industry secret, not secret. We just tell everybody that because everybody thinks that, and we can like stand on that if we want to stand on that. But ultimately, when you're the nurse taking care of a patient, you get to decide. You can supersede rules. I will tell you that. Now, when I was a new nurse, I was scared to go against the grain and advocate for my patient if I thought that there was an actual policy, or if I thought that the expectation from everybody was to follow a certain way. But as I've learned and grew comfortable, I don't have one problem saying, you know what, I'm going to let 10 family members in because this is important. But on the other hand, I've also decided that the family was causing drama and the patient was super stressed, super anxious, and it wasn't healthy for them. And they were more tearful and everything. So I've said, we're going to be doing a procedure shortly, or we're going to be doing some tasks, and we're going to have to close visitation for like the next 2 hours. Please, feel free to go to the waiting room, or you can go by, our coffee shop. You could go, y'all need a break too. Like, y'all been here all day. Like, y'all go treat yourself, get some rest. And then in about 2 hours, about like 5 o'clock or something like that, why don't y'all come back and you can come back in. And then I communicate with my charge nurse about that. And I communicate with the triage nurse about that in the front of the ER. I'm like, we're kicking the family out, but we're doing it in a nice way. So you have to always see if there's an issue or not. Now, if they are disgruntled and they are actually causing issues, you might need to get your charge nurse and or security involved, but that's like a last resort. We want to be meeting the needs of our patients first. Now, I'm going to show you this picture right here. I will tell you that when I had Harper, my baby Schnookums, I was dying to get to the NICU to see her. I hated that they had to take my baby away as soon as she came out. Like, that baby is my baby, and she was attached to me for how many months, and now she's not, and it's the most unnatural feeling on the planet as a mom. So she's in the ICU. And then I was kind of in the ICU too, but whatever. So when they were finally able to get me to go down there and see her, I was like, you're going to have to kick me out. And being able to be in that room did everything for me. So for those of you going to work in both mother baby, L&D, NICU, I want you to remember we need to unite mommies and babies, but even daddies. I sent my husband off with Harper, as soon as the NICU team was like, yep, we got to take her. I was like, go. And I was like, you need to stay with her. She needs somebody, because I couldn't go. And the fact that they allowed him to go the whole time, he was able to hear everything they were saying and doing. And he was taking notes so that he could communicate it back to me, so that I kind of felt like I understood what was going on. Because otherwise, I mean, it was just, there was so much chaos with her, with me. And so the fact that where I was able to be in the hospital, they had completely open visitation, was amazing. Then I got discharged home. She was there, but I could come up all day, all night, anytime I wanted to go and see my baby. I could stay there 24/7. That's one of the reasons why I love the hospital I delivered at, because they actually have private NICU rooms with beds for the mom and dad. How amazingly patient-centered is that, right? I wish all ICUs and every single corner of the world were all private and they all had comfortable beds for family. Ugh, it would just be amazing. Anyways, so just had to point that out. Don't forget, it's not just ICU. I know we think about ICU for adults, but ICU for kids, for babies, for children, we need to let those parents in as long as they're not interfering and it's not like a safety issue. So visitation of children in critical care. Now, this is we're talking about the benefits of children that are not patients coming to visit in the critical care setting. Okay. So the presence of children in the ICU can be a double-edged sword. On one hand, allowing children to visit their critically ill family members can provide immense emotional support for both the patient and the family. For instance, a grandparent in the ICU might find great comfort in seeing their grandbabies, but which can improve their mood and potentially actually help them recover. But on the other hand, the ICU environment can be overwhelming and frightening for children. And we're talking about ICU, but this is the same for the ER, okay? Potentially leading to emotional distress. So therefore, we got to think about this, okay? And you kind of have to balance it. It's important to have clear guidelines and considerations in place to ensure that a child's visit is appropriate and beneficial. Preparing the child for what they will see and hear in the ICU is crucial to minimize any negative impact. This might include explaining the situation in age-appropriate language and offering reassurance throughout the visit. So again, I'm going to give you another example of so it was, the hospital I delivered at was great for the whole NICU thing, horrible when I ended up in the neuro ICU. And I just want y'all to think about this. If you have a patient, similar to my experience, okay? You're taking care of a patient that knows too much. They know what's going on. They're fully aware that they just were told that something's going on, that they may actually die in the next 24 hours, okay? There's like a 50-50 shot. They're young, they have kids. What do you think they're going to want to do? Do you think that they're just going to want to sit there and call them on the phone? No, they're going to want to see their kids. If they might die in the next 24 hours, they're going to want to see them and talk to them and hug them and love them and what? But the ICU that I was in didn't allow children. Thank God for FaceTime, because it was a little in between. But I had to call FaceTime and say goodbye to my children because we didn't know what was happening. I had to say goodbye to my parents. I want y'all to think about that from both a personal perspective. If you were sitting in a bed and you got told horrible news, whether you're going to die or not, it's horrible news. If you have horrible news, don't you have like a person in your life? Like, I mean, I have my person. My person is my husband. But like, almost everybody has somebody, your mom, your dad, your best friend, your significant other, somebody that you want there. And if you have closed visitation hours, closed off to children, this could greatly impact the psyche, the mental health of your patients. And I was a mess for a long time. I couldn't stop crying. I just kept crying and crying and crying. And I know that that's probably just a natural part of the situation, but let me just say that if I had had a chance to have Hannah and Haley up there with me, I would have, oh my gosh, I honestly believe it would have made a huge difference. But remember, this is why it's important to be nosy with your patients. When you first meet them, like, hey, small talk goes a long way. Knowing if they have kids, knowing if they have a family nearby, knowing all these things will help. And like, not every kid is the same. My children could handle the ICU. They're not scared by medical things because they've grown up around it. They've heard about it their whole lives. Other kids might be. But the policy at the place that I was at was they took it as that children under the age of 12 were not allowed in there. And that just stunk to high heaven. So, family presence at death and during a code. Okay, this is another big one. And I'm going to speak from the point of view of a pediatric nurse, pediatric ER nurse. Let the family be in the room. 100%. There are selfish reasons, but then there's also the complete right thing to do, the compassionate thing to do, let the patient be in the room. So, family presence at the time of death or during a code is a deeply sensitive issue that requires very careful consideration, okay, as a nurse. For many families, being present during these moments provides emotional closure that they won't get any other way and a sense of involvement in their loved one's final moments. However, this can also be distressing and it may raise ethical considerations, such as the potential for emotional trauma or interference with the medical team's efforts. The impact on the healthcare team is another factor, as the presence of family members during a code can add pressure to the complexity that is already in this intense situation. It's essential to prepare the family for what they might witness. So before they come in the room, you briefly explain, okay, your mom or your brother or whatever is his heart has stopped. Very simplistic terms. You're not going to use medical terminology. We are actively doing what is called a code. You're going to see lots of people in the room. You are going to hear lots of beeping. I promise that we are doing everything within our power to help your loved one. You are going to see people pushing on his chest, medication administration. You're also going to see people looking up things in the computer and stuff. If you have any questions, please ask me. This is also where it's amazingly great if you have a chaplain or a social worker, case manager, any supportive staff that responds to codes, because they often will stand off to the side next to the family and explain things as they go. This was actually one of my favorite things to do whenever I would show up to a code and like there was enough people in the room already, is I would go find the family and stand next to them, introduce myself and say, I'm here if you have any questions, I can explain what's going on. And very often they'd be like, well, what is that guy over there doing? And I'd be like, oh, he's grabbing the tubes and he's hooking up. See, they're squeezing that bag and that's the air that's going in and out right now, but they're hooking him up now to the machine that's going to breathe for him. Oh, okay. It's just simple. And it provides them so much comfort that somebody's next to them, that helping them understand what's going on. Okay. So make sure you prepare them for what they might witness, offering those clear, simple explanations about what's going on, letting them know that you're there for them. Then after the code event, don't just walk out the room and start talking about, we got to call the medical examiner, life gift, or whatever the case may be. The family's there, and just ask them if they have any questions. We're going to go over in later things like forensics. So if the body is a crime scene because the death was because of some sort of trauma or assault, it's different about what you can let the family do, especially pediatric patients. We'll go over that later. But for the most part, let them sit there, bring a chair by the bedside, let them hold their loved one's hand. Okay. Encourage them, because this may be the last chance that they get a chance to see their loved one, okay? But ultimately, the decision should be guided by the family's wishes and the clinical situation. It's a case by case basis, okay? But you should always prioritize the patient's dignity and the family's emotional well being, not just what you would prefer because it would make your job easier. No, no. We want a patient's dignity and family's emotional well being. So, some culture kind of new topic, some cultural considerations in critical care. Okay. And this is not specific to critical care. This is pretty much everybody in the hospital, but we need to just go over it for measure. Cultural competence is the fundamental aspect of providing a holistic care in the critical care environment. Each patient brings their own unique cultural background, which can significantly influence their health beliefs, practices, and expectations of the care that they are receiving. As nurses, it is our responsibility to respect these cultural practices, even if they differ from our own personal ones. They may involve dietary restrictions, specific rituals, or preferences for modesty, even preference for the male versus female and caregivers. So incorporating cultural needs of our patients into the care plan not only enhances patient comfort, but it also improves compliance with treatment, as patients are more likely to trust you and engage with the healthcare providers who respect their cultural values. By being culturally sensitive, we can provide care that is both effective and compassionate, ensuring that patients feel understood and respected. So sometimes people are like, what is culture? I don't care what anybody says. Everybody has culture, because what culture is it's what they consider to be normal actions. You could write a book for every single person, like what they value, if they have rituals, who their heroes are, who they look up to and aspire to be, just the stories of their life, like all that comes together, and the stories of their loved ones and stuff like that. And so, yes, it includes religion. Yes, it includes, a lot of people always think of it as religion and nationality, but culture is so much more than that. Okay. And keep that in consideration when you're talking to your patients and you're creating holistic like care plans for your patients. So let's talk about the thing that drives me the craziest. Noises in the ICU or in the ER. Okay, so the ICU is often noisy and bright. Okay, same with the ER. It is a very active environment, but though it's necessary for patient monitoring and care, it can have significant negative effects on our patients. The continuous exposure to noise, such as alarms and equipment, can disrupt sleep cycles, leading to sleep deprivation. This is a very, very real thing in the ICU and in the hospital. We're going to go a little bit more of this in a future lecture on sedation and stuff like that, but this is, we need to make note of it now too as well. The lack of rest can exacerbate the stress and anxiety that the patients are already going through, which can turn basically it can slow down the healing process. Okay. Bright lights, especially when they are constant, can interfere with the body's natural circadian rhythms, further contributing to sleep disturbances. Guys, eye masks, they're wonderful. I personally there's so many times where I will offer a patient like a little, we don't have eye masks in the ER. Probably sure they don't have them in the ICU either, but I will get a washcloth and roll it up and be like, here, put it over your eyes. And sometimes they're like, no, because most people don't use eye masks. But I'm like, no, the nerd in me has to explain to them. Look, like, go with me on this, okay? Like, you have receptors in your eyes that can detect light or darkness, whether your eyes are open or not. Your eyelids are not like solid steel, right? Like, you can detect if there's light or not with your eyes closed, right? Yes, yes, yes. So when there's complete darkness and your eyes, like your body is not detecting any light coming through, your body actually starts producing melatonin. Melatonin is the hormone that helps you fall asleep. I'm dead serious, especially you night shift workers, your future night shift workers, patients in the hospital. If you're having a hard time sleeping and staying awake and you're all off the whatever, like night shift nurses, you have to sleep during the day. Yes, everybody talks about like blackout curtains and this and that, but it's never fully dark. And a lot of people have electronics in the room, and even those little bitty lights, little bitty blue light here, little bitty TV light over there, those things, your eyes can detect it. And you're not getting as much restful sleep as you can. And they've done studies on this. If you get those, if you wear an eye mask, like my husband, he's so funny. He wears an eye mask and it's hilarious. I have so many pictures of him because why not sleeping with an eye mask on just because I like to make fun of him in a loving manner. But it's like taking, I mean, I'm exaggerating here, but it's like taking an Ambien. When you put that on, it's like you get a hit of melatonin to your body that's naturally occurring. And I fall asleep so much quicker and stay asleep longer when there's no light hitting. So for our patients, help them out, turn the lights down, but you can never make it out. Try to say, do you sleep with an eye mask at home? Encourage loved ones to go get one. If not, as long as it's safe and it's not like an airway issue or whatever, like don't do this to a baby, but try to put something over their eyes. It will help them mitigate, like close the curtain, those kind of things. I know that you've got to see the patient in the ICU, but I'm telling you, when you don't get any sleep and there's an ICU nurse coming in there every 15, 20, 30 minutes, you want to go crazy, okay? So help your patients out, okay? So, so to mitigate these things, so one of the strategies I already talked about is covering the eyes, but we can also offer earplugs, noise canceling headphones, encourage them. Hey, do you have AirPods? Maybe have your significant other bring them up to the hospital. That would be awesome. I actually asked my nurse for those, like the same little earplugs that we provide you guys sometimes in the testing center, like the little foam ones. I was like, can you please help me? And she's like, oh yeah, we have those on the unit. I was like, oh, score. I was so happy. I was like, praise Jesus. And I would put those earplugs in and world of difference. Oh, world of difference. Okay. I'm saying as a patient, not as a nurse. I would never put earplugs in as a nurse. But anyways, so also trying to create quiet times where non-essential noise is minimalized. I will tell you, again, I've seen this happen so many times. It's very rare in the ER. I'm sorry. We're ER nurses. We're just mean. That's a joke. We're not, but it's just kind of the nature of it. But the ICU nurses, I've seen this time and time again, especially the night shift ICU nurses. They will say, look, this is I have to check on you, blah, 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 this time, and this time. You're due for pain meds at this time, or you're due for an antibiotic at this time. When they work with the patient to figure out like a good 2-hour block where I'm just going to look at you through the window and I'm not going to come in here between this time and that time. So I'm telling you, I'm going to try to minimize my distractions for you. So that go to sleep. Don't play on your phone during that time, that kind of stuff, if they're capable of playing on their phone. But this is also true for the family members in the room. They need to get sleep too, okay? Because they can become cranky too and a little mental health issues when they don't get any sleep. Encourage them to go home. They probably won't do that. But minimizing distractions also helps them. Oh, and we're going to go back. There's a reason why there's that red light down there, the little stop sign. I can speak to this. The ICUs, they have these and they're like noise sensors. You can actually buy them on Amazon. They're amazing. And so you set them at decibel levels, and when the noise is down, it's green. And as the noise level starts going up to yellow or red, it's getting too loud, and that lets everybody know it's quiet. These are very common in NICUs. You may have had them in a school classroom growing up, because I know some teachers buy these too. I've wanted to buy them for my house because my children are very loud, but they're really cool. And so if you ever go in an ICU and you see that red light thing, just know that if it's yellow or red, you need to be quiet. Okay, so sleep deprivation in critical ill patients. This is a serious concern and it has far-reaching consequences. The lack of sleep can lead to cognitive impairment, making it difficult for our patients to think clearly, to communicate with us, and to understand what's going on. This is particularly troubling in an emergency room or the ICU, where clear communication and understanding are kind of essential for them to be able to make decisions on their care or what's going on, right? Moreover, sleep deprivation can delay recovery, as the body just needs to rest to heal and regenerate tissue. It also increases the risk of complications such as infection or delirium. Delirium is a word that you're going to need to know for behavioral health, but it's good and applicable here too. Delirium, which can prolong the patient's stay in the ICU. Promoting the rest in the ICU is therefore a top priority. This must, it's a top priority, not more so than like airway or breathing, but it is important. This might involve creating an environment conducive to sleep by reducing the noise and lights. We already kind of talked about this. Scheduling, so like you can schedule those activities, like, nurses, ICU nurses are so much better at this than ER nurses. So that you just try to like minimize those times going in. Just remember, the ICU, you have to be monitoring your patients way more frequently than a med-surg unit. So med-surg, it's so much easier to say, oh, I'm not going to interrupt you for 4 hours. That's really hard to do in the ICU, but do it as much as you possibly can, okay? So some strategies to decrease sound and sensory overload. So there's some pictures on here just because these are the bane of my existence. Like, I hate beeping, and I know I chose the wrong profession because beeps drive me crazy. But when you have look at the top photo, you have multiple monitors, you have multiple lines, IV meds running. Every single one of those suckers can be beeping, and they could all be beeping at the same time, and maybe even the bed is beeping. And then what if the computer workstation that's right there hasn't been plugged in a while, and then it starts beeping, and there's beeping everywhere? Okay, now the question is can you turn off alarms? The answer should always be no. Okay, you should never turn off alarms. Do nurses do it? Potentially. You can turn them down, but there's a reason why alarms are on patients. Okay, now it's important to note that sometimes, you can change the ranges based off of your specific patient. So the alarm ranges. So like a heart rate, like it's typically like what, 60 to 100. So if it goes below 60, you're going to start having alarm sounds. Well, if this patient has been living at like 102, 105, you could potentially ask for permission from the physician if it's okay for their heart rate to be okay and to move the alarms. That's kind of going a step above. Do nurses do it? Yes, you're not supposed to, but you're going to see nurses that will change the alarm so it doesn't go off as frequently, but it would like let them know the danger signs. But on the flip side, sometimes you put a patient on a monitor that was on a different patient before, and you always need to double check the ranges for alarms to make sure that you will hear it when there's an issue with your patient. Because if it was like a pediatric patient before an adult patient, we all know they're going to have different vital signs and different norms. Just always double check that you make sure those alarms are going off where you can hear them. Okay, they're there to help us. Okay, so some ICUs have successfully used white noise machines or soothing sounds like ocean waves and soft music to create a more calming atmosphere. Hey, that sounds kind of cool, but also annoying at the same time. Reducing the light intensity, especially during the night, helps to maintain the body's natural sleep-wake cycle. We already talked about that, and promote better rest. Okay, so these strategies not only improve the patient's comfort, but also contribute to a better health outcome by allowing the body to rest and recover more efficiently. So complementary therapies in critical care. So, these pictures aren't really like in an ICU, and they're kind of, silly, but it's true. So therapeutic touch, y'all, holding somebody's hand or just patting them like on the shoulder goes so far. Like, don't be afraid to touch your patients in an appropriate way, okay? So complementary therapies have become increasingly recognized for their potential to enhance the care provided in the critical care setting. Now, this is more in, like I said, the ICU versus the ER, because the ER, nobody wants to support us in things that make people happy. It's just boom, boom, boom. But the ICU, you can sometimes find these things, especially in a pediatric ICU. So therapeutic touch, for instance, can help reduce pain and anxiety by promoting relaxation and a sense of connection. Relaxation techniques such as deep breathing exercises or progressive muscle relaxation are effective in calming the mind and body, making them valuable tools in the ICU. Music therapy, which involves listening to soothing music or potentially having somebody come in and play a musical instrument for you, has been shown to lower heart rate, blood pressure, creating a more serene environment, or just boosting the mood of the patient. So guided imagery, where patients visualize peaceful scenes like they're planning their own, Hawaiian vacation, that kind of thing, or positive outcomes. So they're visualizing themselves healing from their disease process and walking out of the hospital. So guided imagery can also reduce stress and improve overall well-being. Integrating these therapies into the ICU not only provides additional comfort to patients, but it also aligns with our holistic approach to care, addressing those physical, emotional, and spiritual needs of our Well, our patients, not our family, but that works too. Okay, so just a little review over what we talked about today. Okay, so to review the module, let's recap on some of the key points we just covered. We've explored the critical care environment. We emphasize the importance of holistic care that addresses the physical, emotional, and spiritual needs of our patients. Okay. We've also discussed the significant role that nurses play in reducing stress and anxiety, involving the families in the care as much as possible. We also discussed respecting cultural and spiritual differences. As we move forward, I do encourage all of you guys to think about how you can apply these concepts in your own practice. Think about where you want to go and work, whether it's the ICU or the OR, the ER, pediatrics, L&D, wherever it is. Think about how you can incorporate these because these are actually applicable, like I said, everywhere, okay? Remember that every patient that you encounter is unique, okay? And by providing care that is truly holistic, we can be more meaningful in in what we do and the care that we provide. Okay, so thank you guys for your time and your attention listening. I look forward to seeing all you guys in class this week, and I also like to see and can't wait to see how you're going to incorporate these ideas into your clinical practice. You are now complete through Module 1A. Don't forget to review the readings. Make sure that you're going to go over the learning objectives for the module, okay, before we go to lecture. Make sure that you can basically answer and provide if we were to do activities on this content, okay? And I will see you guys in class.